The pilot number 1 of the BigMedilytics is devoted to the field of chronic diseases. Chronic diseases are the main cause of morbidity and mortality across Europe, and the management of this requires coordinated inputs. And one of the important issues at the beginning is to assess what is the risk and what is the impact of risk, because these diseases have one condition, that is the comorbidity. What is comorbidity? Is the co-occurrence of 2 or more of these chronic diseases. Despite that previous efforts try to evaluate what is the burden of this combination of diseases, there is no information about what are the best approach when we are considering the clinical impact. And in this, the objective is to identify the distinct comorbidity groups, the amount of risk of each disease inside of the cluster, and what is the potential impact of controlling the modifiable risk factors, clinical variables that the patient have. For this, we use one analysis of the data provided for the electronic health recordings of the Valencian community with more than 4 million of people, and we perform a hierarchical cluster that include sex, age, 19 of the most frequent chronic diseases and 6 of the relevant clinical variables. With this, we are able to provide what is the risk for one patient as a whole, but also what is the impact in the risk of each of these elements: sex, age, each disease, and also clinical variables. For that, we provided with 2 interesting tools. The 2 interesting tools, one is a dashboard that displays information about the distribution of the specific comorbidities in the cluster, how common is in the selected cases in the overall amount of the people that can be attended by the physician, and also can provide a diagram showing the relation between the different comorbidity clusters. And what was more useful, an app suitable for tablets or for smartphones, in which rapidly the overall risk of the patient is calculated, but also we are able to identify what is the amount of the risk that pertain to each of the diseases and also to each of the variables. With this, the physician can take actions giving more attention to those diseases that produce more risk, and how to provide the best treatment not only for this, if not also to try to assess what can be the impact see other diseases appears, other diseases that can be derived from the chronic ones that are present in the patients.
Patients after kidney transplantation require lifelong specialized care in order to prevent rejection and avoid hospitalizations. Within the kidney pilot, we were able to develop a telemedicine care for patients after kidney transplantation, including a patient app and a telemedicine dashboard. Based on our patient data and in close cooperation with our partners and DFKI, we developed excellent prediction models on the probability of graft loss, infections, and rejection. With help of these tools, we are now able to better detect critical situations and reduce hospitalizations, and by this means provide more support to our patients in order to increase quality of life.
Our pilot focuses on the integration of information and communication technology to the healthcare management of a cohort of obstetric patients with gestational diabetes. Traditionally, glycemic control in gestational diabetes is monitored through self-directed finger prick blood glucose testing, with results typically stored in a paper-based diary for review at the next clinical encounter. Frequent outpatient review of recorded glycemic data is therefore mandated to ensure optimal and satisfactory control of the condition. However, the rising prevalence of gestational diabetes nationally and internationally means that continuance of this outpatient care delivery pathway is under enormous pressure and has become untenable. Novel approaches to combating such stresses are desired, and this pilot represents one such approach. Integration of information and communication technology to gestational diabetes service provision has far-reaching benefits for patients and their caregivers, including a reduction to the burden of service delivery, a welcome benefit in an overstretched system, maximisation of efficiency for patients and their caregivers, cost reduction for the hospital infrastructure itself, in addition to envisaged cost savings for patients due to reduction in transport costs, childcare costs, and less absenteeism from work. Finally, the work produced by this pilot facilitates education development and patient-centred care, key components of continued patient engagement and compliance with recommended treatment goals. Through the collaboration of science, industry and technology, this pilot group has developed an app-assisted management algorithm that enables a woman with gestational diabetes to self-monitor and self-manage her condition, obviating the need for the majority of women to attend an in-person obstetric diabetes service, a goal in fact that took on invaluable merit with the onset of the COVID-19 pandemic. The self-management programme involves a smartphone app linked to a secure portal where staff can review glycemic control. Results of finger prick blood glucose testing, the gold standard for gestational diabetes surveillance, are uploaded from the glucometer using Bluetooth technology to the app on the patient's smartphone. This data is subsequently analysed and available for review on the hospital portal by the obstetric diabetes team, allowing easy identification of those patients with above threshold glycemic values where a more intensive management approach is warranted. When desired levels of control are met and maintained, the patient will receive positive feedback through her app and will not be required to attend outpatient visits because of her diagnosis of gestational diabetes. In the final stage of the pilot, the initial analytics model will move forward towards a more predictive approach as more data becomes available, for instance, logs of food intake and activity tracking information. These can be used to fine-tune current analysis and develop a predictive component to facilitate the early identification of potential risk scenarios for patients diagnosed with gestational diabetes. Our app-assisted self-management programme has already resulted in a reduction in the burden of service delivery for staff working in the clinical site, the Rotunda Hospital. It has maximised efficiency for patients and their caregivers while fostering education and patient-centred care. To date, the adoption of this AI technology to GDM management has been reported by the end users as acceptable and feasible, and a welcome replacement to an outdated paper-based system which was both burdensome and susceptible to human error. We are continuing to recruit patients to the study, and as such, clinical outcome data is not yet fully available.
Hello, my name is Michael Boniface and I'm the Director of the University of Southampton IT Innovation Centre. I'm here today to talk to you about the BigMedilytics pilot aiming to use predictive models to help patients living with COPD. The pilot is a collaboration between the University of Southampton and MyM Health Limit and aims to use machine learning to develop models that can predict COPD exacerbation events several days in advance. COPD is a life-limiting condition, is an incurable condition and is expected to be the third leading cause of death by 2030. And patients living with COPD have to manage their condition by activities and therapies and drugs, but sometimes their condition exacerbates. And an exacerbation is a significant worsening of condition and can lead to them needing to seek medical help, and in some case ends up in hospital admission. Now, by trying to avoid the severity or the frequency of exacerbations, what we can do is slow down the deterioration of lung function and improve the quality of life of patients. So what we have achieved in our pilot is to train a machine learning model that predicts exacerbation events several days in advance. We did this by working with our partner MyM Health Limited, working with their platform MyCOPD, which is deployed widely across the NHS. The digital platform MyCOPD has engaged tens of thousands of patients in reporting symptom scores over many months and years, and we combine that with other factors such as demographics and lifestyle to develop our predictive model. The outcome has demonstrated that for the very first time we can now identify which patients are to exacerbate, and what that allows is for us to be able to intervene early and try and reduce the severity and frequency of exacerbation in some of the most vulnerable patients in our society. Now, our next steps are to undertake a trial of the results of BigMedilytics within health systems. To achieve that, the University of Southampton, collaborating with MyM Health Limited, the University of Bath and the University Hospital Southampton, have won a major AI award. What we'll do in this AI award is we'll undertake a trial with patients across the UK and look to how to deploy such predictive algorithms into the NHS. We'll be working with patients and clinicians to co-design new care models. We'll also work with regulators and those developing guidance for AI, such as NICE, to ensure that the solutions provided are safe, effective and acceptable to both clinicians and patients. So the BigMedilytics pilot has been hugely successful. For the first time ever, we have a model that will predict COPD exacerbation several days in advance. This has huge implications for patients and will deliver better health outcomes for them. Through early advance warning, they will now be able to seek interventions and mitigations to the severity of their deterioration, and as a consequence of that, their lives will be improved and the deterioration of lung function reduced dramatically.
Hi, my name is Arne Ibma and I would like to give you a quick summary of the achievements of the BigMedilytics Pilot 5 on heart failure. As heart failure has a high healthcare burden in our current society, efforts to decrease this burden are of high significance. In our pilot we have 3 partners that are based in the Netherlands: Achmea, an insurance company, TNO, a technology research institute, and Erasmus Medical Center, a hospital. The overall goal of our pilot was to identify an intervention for heart failure patients that would contribute to a decrease in mortality and in healthcare costs. To identify such an intervention, we first needed to develop a machine learning approach on a large heart failure patient dataset, thus allowing us to identify novel comorbidities of heart failure. We needed to perform this machine learning analysis on privacy-sensitive patient data which is residing at different institutions and who are not willing to share data with each other. In this case, an insurance company and a hospital. For this reason, we needed to develop a secure and GDPR-compliant data sharing process to allow us to run our machine learning analysis on this data. The insurance company Achmea was successful in developing an elastic net machine learning approach to identify novel comorbidities of heart failure. The Technology Institute TNO was successful in developing a multi-party computation approach to run this machine learning approach in a secure and GDPR compliant manner as a proof of principle on datasets residing at the insurance company Achmea and the Erasmus Medical Center Hospital. Subsequently, the Erasmus Medical Center has identified an intervention in heart failure patients that leads to a decrease in mortality and healthcare costs. So with these results, I would like to conclude that our pilot successfully reached its goals and all three partners are very proud of their results. Thank you.